Um, Good evening, everyone. My name is Mai. I am the chair of the Hmong Public Health Association and also a trained epidemiologist. Um, and then I will pass it on to Jason.
Hi, everyone. Sorry, I have to turn off my camera, but my name is Jason Yang. My PGPs are he, him, she, her, and I am the planning lead for HPHA. So welcome, everyone, and thank you for joining us. Denny?
Thanks, Jason. Thanks, Mai. So this is Denny Vang. I use he and his pronouns. I work at the Center for Health Statistics. And so working very closely with our community organizations and partners internally as well as externally to think about data standards. And with this timely sort of piece and presentation, I hope that you all can kind of learn about what's been going on and have some takeaways from this presentation. So without further ado, I will share my screen and Mai will kick us off.
All right. Thank you, Denny. And I also want to thank everyone else for joining us this evening and spending a bit of time to talk about, a very important topic of disaggregated data in the public health field right now. As I said, my name is Mai Vue. I'm an epidemiologist and the chair of the Hmong Public Health Association, which is a national grassroots organization with a network of about 60 Hmong public health professionals and students around the U.S. And we've been around now for about 3 years since our report was released. And so I also want to give a thanks to the Minnesota Public Health Association for inviting us to present on this topic and graciously, giving us space to talk about our experiences and discuss the work that we're doing to promote data equity for historically underreported and underrepresented communities. Additionally, I want to give a special acknowledgement to Chao Yang and Chao Yang, who have contributed immensely to this work. And many of the slides that I'll be presenting today are alterations of presentations and conversations that they've previously given. Today's focus will be on disaggregated data and why it is important for Asian Americans in Minnesota. Next slide, Denny. And so when we're talking about the Asian American community in Minnesota, it's important to acknowledge what the current picture looks like for our, diverse community. We know that Minnesota is a melting pot, but what does that actually look like in Minnesota for our Asian community? When we look at aggregated data on the Asian population in the US, we continue to see a perpetuation of the stereotype that there are a model minority, and we'll delve more into specifics in the following slides. And we also know that Asian American and Pacific Islanders are diverse and represent over 40 different ethnic groups, and that AAPI individuals are the fastest growing population in the US. In Minnesota, the Asian American community makes up about only 5% of the state's total population. And on this pie chart here, you can see the 10 largest Asian ethnic groups in Minnesota, including our largest group, the Hmong community, who makes up 31% of our Asian American community. And I want you to try to remember that statistic, the 31%, for a later comparison. And then our second largest group is American Indian, Asian Indian at 16%, Chinese at 11%, Vietnamese at 9%, Korean at 8%, Burmese at 6%, Filipino at 4%, Cambodian with 4%, Laotian at 3%, and Japanese at 2%. Next slide, please, Denny. This slide takes a look at the income statistics for in Minnesota for the Asian American community. And looking at our aggregate statistics on the left-hand side here, when we compare the median household income of the Asian population to the total Minnesota population and the white population, it looks like we're doing pretty well, right? We're coming out on top. However, when we break it down into income per capita, which is that on the left-hand side there, that lighter colored bar, we see that individual income is almost $10,000 less compared to the white population and the total population. And this example shows us that we need to look at per capita income instead of household income in order to better understand the Asian American economic situation, because this population tends to live in multi-generational and or larger households. And so it makes sense that if you have more working people who live in one house, you'll likely have a higher household income. When we disaggregate the data by ethnicity on the right-hand side here, we can see a wide spectrum of income. We see that Asian Indians have nearly 4 times as much household income as the Burmese. Hmong and Laotian communities have both low, median household income and per capita income when compared to other groups. And just to keep in mind, per capita income could also suggest that there are only a small number of high income earners per household, potentially that there are larger household size, or there are only a few income earners per household. Next slide, please, Sunny. This slide takes a look at employment statistics in Minnesota. And again, aggregated data on the top section there shows that across the board, overall, state population, white population, and Asian population, employment status is relatively the same, right? Disaggregated data, however, tells us a little bit more. The unemployment rates are twice as high among those in Cambodian at 8% and Hmong 7% compared to the general population of 4%. And, we also have to keep in mind too that for, those in the Burmese community, they could potentially have such a high, proportion that are not in the labor force because of how young their population is. We're not talking about, we won't be discussing age breakdown today, but the Burmese is one of the youngest Asian subpopulation groups. And so that's just something to keep in mind. Next slide, please, Sunny. In terms of education, this graph is taken from the National Center for Educational Statistics and provides statistics on a post-secondary degree attainment by aggregate race groups. And it's common for us to see data reported like this with these racial categories. And you'll see that when the data is not broken down, Asian Americans are performing above all other racial groups between the 2010 and 2016 data points. Compared to the total US population, it seems that Asian Americans have a much higher bachelor's degree or higher attainment at 54% versus 31% in 2016. And so without looking at other communities within the Asian groups, this figure paints an incomplete picture. Next slide, please, Sunny. And so when we break it down, this chart is from the AAPI data group, and it shows a breakdown of data by ethnic group within the Asian American racial category using data from the 2015 American Communities Survey. And to remind us of the national and aggregate landscape from the previous slide, which showed us that approximately 31% of the total US population have a bachelor's degree or higher, and 53% of Asian Americans have a bachelor's degree or higher. When we disaggregate the data, again, we see a wide spectrum of post-secondary attainment, with 75% of Taiwanese and Asian Indians having a bachelor's degree or higher, while on the other hand, we only see 17% to 14% of Hmong, Cambodian, Laotian, and Bhutanese attaining a bachelor's degree or higher. And so those are, really big differences that we see just within the Asian community. Next slide, please. And so all of the indicators that I just discussed are part of what we know as the social determinants of health, right? These are experiences and social factors and systemic barriers that continue to contribute to health outcomes for our especially vulnerable populations. These social determinants of health indicators are integral to understanding what the current landscape is for our Asian American communities and how it has manifested in health outcomes especially in the case of COVID-19. Next slide, please, Denny. From February 2020 until early spring of 2021, local, state, and national Hmong healthcare professionals convened to share what they knew about how COVID-19 was affecting the Hmong American community. However, most, if not all of the information was aggregate information, lumping all Asian cultural groups into one category. The current information that's used to communicate to the public doesn't allow for the Hmong or Karen cultural communities to assess the burden of COVID-19 beyond perceived individual and collective experiences. As a result of an unmet need, HPHA's founder, Chao Yang, spearheaded, in collaboration with Chao Yang, who at the time was with the Coalition of Asian American Leaders, our team at the Hmong Public Health Association, and researchers J.P. Leiter and Elizabeth Wrigley to disseminate Asian COVID-19 mortality data by cultural subgroup. This report drew attention to the disproportionate number of COVID-19 death rates among Hmong, Karen, and Karenni residents, and provided recommendations to address COVID-19 infections, prevent further deaths, and ensure that prevention strategies were responsive and relevant when serving Asian Minnesotans. For example, the report found that although the Hmong community made up approximately 30% of Minnesota's Asian population, we represented 50% of the deaths in the Asian community. And with my epi cap on, this means that we were seeing an overrepresentation of deaths in the Hmong community. And in other words, if we were experiencing the same burden of COVID-19 deaths compared to other Asians in the Minnesotan community, our deaths would have been equivalent to our population rate at 30%. So when we take a look at age breakdown, we see that Hmong deaths were occurring in younger age groups compared to the white population, where a majority of deaths were in the 80 plus age group. And if we try to recall early COVID-19 messaging from public health authorities, the reports were stating that COVID deaths were more likely to occur in the 80 plus age group, which we see here is not true for the Hmong community and may have contributed to a decrease of public sensitivity to the actual impact on the Hmong community. Additionally, when we look at the data closer, we see that the factors increasing risk of death and disease were not due to poor personal choices, but due to systemic barriers, including multi-generational living situations where there's a household of grandma and grandpa, mom and dad, and kids. Having essential worker status or employment, such as being a farmer, and having underlying chronic diseases and obesity, which we know that the Hmong community experiences these at a higher rate than our predominant communities. And what we've been talking about, right, the exclusion of Asian American subgroups in targeted response, such as resource allocation, were all factors that contributed to these unnecessary preventable deaths. This tool served as the evidence we needed to advocate for more targeted vaccination efforts in zip codes with dense Hmong residents, and ultimately led to the creation of the Demographic Data Collection Standard, which is a toolkit that we've been working on with the Minnesota Department of Health to develop. And it'll be, the first of its kind in Minnesota. And Denny will be presenting on this next. The COVID-19 pandemic showed us how vulnerable our public health systems are, and that we still struggle to protect our most vulnerable communities. Disaggregated data is important and should be collected and used to better understand the complexity and lived experiences of different Asian Minnesotan communities. In other words, the one-size-fits-all approach that views Asian Americans as a monolith simply does not work for our communities. Furthermore, disaggregated data better captures the patterns within a subpopulation that may be hidden with aggregated data. This can be used to support program development, implementation, monitoring, and evaluation. With this disaggregation effort, public health agencies were able to prioritize vaccination of communities with high infection and mortality rates, as reflected in the report, by increasing outreach, engagement, and prevention education efforts. We know that health disparities are a result of a complex layer of racial, economic, educational, and other social factors. And this is apparent in terms of mortality rate when they were broken down by zip code. Before the COVID-19 pandemic, the evidence to support the relationship between life expectancies and zip codes were growing. However, this pandemic has made it abundantly clear that preventable deaths as a result of COVID-19 disproportionately shortened the lives of communities made most vulnerable because of race, income, immigration status, age, and other intersecting identities. Future emergency response efforts will likely be required, which means having disaggregated data allows better targeted approaches to promote health equity and close these desperate gaps. And finally, disaggregated data would not only be more inclusive, but would also better inform policymaking decisions and help to build collective community power to, improve the health and well-being for all of our communities. And that's it for my section. I want to thank you all again for joining us. You can read the report on the CAAL website on this slide, or contact the Hmong Public Health Association through the information listed on this slide as well. And I will turn it over to Denny to provide us updates on the Minnesota Demographic Data Standard. Thank you.
Hi, everyone. So let me just pull up the slide deck and then we can get started. All right, so I just wanted to reiterate what Mai and Jason have said. Thank you so much for being in this space with us to talk to, for us to talk to you all about data equity and data standards, and the very real importance of why this work matters for the many communities that we serve in Minnesota. Coming into this space, myself working in MDH from community and from the Hmong Public Health Association, that this is something, as all of you are probably aware of, has been a long-standing issue. And so today I wanted to talk about the work that's been ongoing and the intentional and continuous process of really bridging gaps, bringing in community voices, and trying to really tackle some of these issues that have been in the system for a long time when it relates to data. So without further ado, again, I'm Denny Vang. I use he and his pronouns, and I work at the Center for Health Statistics, supporting Dan Fernandez-Baca, my supervisor, and Nan Watts, who is our recent AmeriCorps Public Health member in the data standards work here. So before we get started, if it's, as you are able to, I will be doing this quick Menti activity. So if you're not familiar with Menti, you would visit the website here, www.menti.com, and use the following code here, which is 72020790, and it will bring you to one of the questions. And so there will be two questions that I have here to kick us off with this presentation. So with that, let me actually swap my screens here. And I will throw the code in chat as well. Okay. So Menti, if you see here, the first question is, which of the 10 public health essential functions do you mostly work in? And it seems like we're already getting some participants kind of marking on this wheel where they mostly interface with with these sections in mind. So, excuse me. As we wait for more folks to kind of chime in, I can see that a lot of folks are working on that policy development side. where we have inform, educate, empower, and mobilize community partnerships and develop policies, which is great. Coming from myself as a policy-based background in public health, it's interesting to see this and the distribution of folks in this space and where you all interface with your work. We have a couple of folks in the assurance side doing evaluation based research, and kind of a mix of folks with doing assurance based programming, and then assessment on the assessment side, mostly focused on monitoring the health of our communities and populations. So I will, and then we do have a person, putting their dot outside, really indicating that they do all of these things in the policy development side. That's great. So I will move on to the next question. So this question is a simple question, and I think it's a great way for us to think about data, but also as the holiday seasons approach, these last couple of months of the year, just a quick question for all of you: what's your favorite treat or dessert choice from these selections? So we're seeing right now, okay, things are moving around, so let's give it a few seconds or so here. I guess we see ice cream really taking the lead here. We have a lot of ice cream lover folks in the call today. That's great. Awesome. So, and then we have the chocolate. Chocolate's great too. So as I swap my screen over to the slide deck here, we'll get into some of the pieces of data, and particularly with this exercise, things that I wanted to highlight about it. So here we go. First, let's ground some of our ideas as it relates to data standards and data equity. For those of you who might not be as familiar with these terms, what we're defining or thinking about in terms of data standards are really the guidance documents, the practices, and the sorts of question stems and responses that need to be used to provide recommendation for capturing data on the populations that we serve. So when we think about data standards, that might be something, if you're all familiar with, such as the OMB 15 race ethnicity categories, or for disability, the Washington short set. And these sorts of questions when it comes to data standards. And then for data equity, considering that there's many sorts of processes to data and its usage and implementation. So data management, collection, analysis, and distribution or dissemination for health services research and outcomes research that can promote informed choices, identify gaps, and as Mai succinctly put it, really looking at how we can better our programming or services or funding and what have you on making these better informed decisions. So why data equity in particular? I think the fundamental question here really is, when we get down to it, who's being reached, who's not, and why. And this really speaks to, again, all these things we have here on this slide. So services, programs, funding, and healthcare provisions. And there's definitely a multitude of things you could add to this, a lot of different nuances. And when it comes to, again, who's being reached and who's not, we know that with the diverse communities that we serve in Minnesota that we have, there are different needs, potentially different challenges, different considerations that we need to take into account, whether it's cultural contextual pieces to historical trauma pieces, to the sorts of needs focused on language and access for different communities. And so to be considering that within that data scope, and that we just don't have all the data that we would like or that we would need to really break down what these gaps are and for what reasons. And so this is why data equity is so important for the many communities that we serve, considering the context of whether that's a race, ethnic, cultural group to the LGBTQIA plus population to disability status. So all these sorts of areas that are very vital to have data on, so we see these populations and they're not invisible. And so I want to take a field trip back to the beginning of COVID-19. And as Mai had presented on the COVID-19 data with the Hmong population focus, we saw during the pandemic that there were a lot of gaps in many different areas for many different communities for numerous reasons. As you can see here, these are real headlines by real authors that published, whether they're journal articles or whether they're news reports. As you can see here, here's the bottom one is the CAAL report that Mai was referring to in collaboration with HPHA individuals. So and researchers. And so, as you can see, we have things related to race, ethnicity, to the LGBTQ plus community, to disability and the rural counties. And really that all this is highlighting the need that we need to focus on better data collection and how to really advance data equity, be intentional about that. Because again, this has been a very long-standing issue. As Jaime mentioned in the beginning of this presentation, introduction, that many of you on the call have probably also been aware of these issues and have really been pushing and have been strong advocates of this work. And so, when coming into this space and then seeing as we've all lived through the pandemic and are in that post-recovery stage to some extent, COVID really was the catalyst to begin the processes of how we at MDH can start thinking about improving data systems. And I would tell you that if my supervisor Dan was here, he would say that it was the community voices, such as HPHA, CAAL, many others internally working on data and with their respective populations, the COVID community coordinators and the liaisons that were interfacing with our communities, that there were a lot of voices really pushing to see a consistency and a better way we can collect data, really improving on all these past things that just are aggregate umbrella racial categories or groups, identifiers, what have you on data. And so what I want to highlight here is that, as you can see in the bullet point, the second bullet point, data requiring solutions or determining solutions rather requires all sorts of data. So this isn't necessarily just things on numbers. And so we have to be considering the qualitative pieces, again, whether it's geopolitical pieces to cultural contextual pieces, and the story that we're showing and the voices behind that, and also bringing in community. So that's really key. And then data usage isn't just important to respective organizations such as MDH or DHS or other state enterprises for programming and services. It's really important, and from what we've heard from communities, this is important for their own usage as it relates to advocacy and outreach and informed decision-making as trusted messengers, as leaders within their own community population to really advance things and work with their community to improve outcomes where needed. And lastly, data drives many things. And so Mai really highlighted that data is integral and integrated in many things. And so as you can see here, data drives things as, what brands and products are being made by companies and who are the consumers, how popular is an item, how is something trending, to something on the right, the middle photo here, where your GPS system on your phone or in your car that's powered by data, whether that's satellite data or GIS systems, and even, traffic times and these sorts of information of locations of places. This is all powered by data systems really interfacing together. And then, you have product reviews, indicated by the star count. Product reviews, maybe that's on Amazon or e-commerce sites, thinking about, folks giving their opinion on products and using that to make an informed choice on something when you buy something. To the last photo here on the right, far right, thinking about healthcare, health systems in general, big data, but even then also thinking about community data, surveillance data, to data that is used in academia, or again, and then that also being an important part of data that we can use for really addressing gaps. And so, and this also includes EHR data, so health and clinic data, and those sorts of things. So just wanted to highlight here that when it comes to the components of data, there are numerous things, and so this is definitely not an exhaustive sort of list on what data contains or what it should contain, but these three things here in particular are things that I wanted to highlight as it relates to, how we can think about data as individuals. So we have usability and functionality, accessibility and sustainability. Usability and functionality really focusing on the matters of, is the data that we have, that we're collecting, that we're showing, or visualizing, is this usable, and is it going to be meaningful to those we serve? Going to the example that Mai had, if we showed COVID mortality deaths and we wanted to show the effect on specific populations, particularly for the Hmong population, and if we didn't have that, is that really usable to the Hmong population that we serve? My population that I'm a part of. And so I think that's something we always have to consider when we are, as data researchers, data scientists, those interfacing with data in many ways that we might not even be aware of. And then secondly, accessibility. Accessibility also considering the functions of, is this something that community members, leaders, to policy folks, to academia individuals, like, are folks able to access this data, use it in the ways that they see fit to, bring about discussion and discourse and good change. And then lastly, sustainability, thinking about leveraging partners, building capacity, and having directional processes that can maintain a good data life cycle. So not having one-offs, not thinking about how, for one data set we have collection here that's disaggregated, in another data set it's a little bit different, or maybe it doesn't actually have disaggregated data collection practices in place. So again, really thinking about these pieces. And then transitioning to this framework here that I wanted to share with all of you, by Heather Krauss, a very strong advocate and supporter of data equity. And so in borrowing her data equity framework in this presentation here, we have funding, motivation, project design, data collection and sourcing, analysis, interpretation, communication, and distribution as the 7 areas of the data equity framework that she outlines here. And so, as I mentioned in the previous slide, we as individuals, we might be data scientists and researchers, we might be programmers and planners, we might be teachers, and we also, again, we wear many hats. And so wherever we are on the spectrum or the continuum of data, how that's used, where that's collected, I would argue that, we, to some extent, are part of one of these areas, if not more than one. And so, and also it's very well the case that the collective power and the voice that we have can really influence this area, or these areas. And so with that, I want to talk about the importance of data. And so at a high level, more broadly speaking here, when we think about data and for organizations or businesses, we see, and as Mai had also had on her slide, the very important piece of how high quality, better data really helps to avoid errors, provide diagnostic accuracy. We need to consider efficacy, and then we also have to consider our precision in terms of disease prevention, surveillance, and resource allocation. We, as a state entity or as state enterprises, as part of government, are bound by budgetary considerations. And so to the extent that we are those and colleagues in the space of needing to make these budgetary considerations, we need to make informed choices so that we don't intentionally cause more harm, or that we are really trying to reduce as much harm as we can, or poor health outcomes and inequities. And in 2018, Gartner did a research, and they found that on average, the financial loss due to poor quality is $15 million. And IBM took that to the next stage in terms of the monetary loss of poor data, in that about $3.1 trillion per year is lost due to poor data. And so this is for, as you can see here, for businesses, but this is also very applicable to the MDH and different state enterprises and organizations, and of course hospitals too, as it relates to the provisions of what they do. So thinking about care, resource allocation again, and funding, to programming, and these sorts of pieces that really are affected by poor data. And ultimately the outcome of what can and perhaps is affected. And so when we think about data and the sort of data equity pieces, as you can see here in this diagram, we have, I would call, several pillars in the center here. Going from left to right, you have the determinants of health. You have then moving to the second one, individuals seeking medical care and support services in our hospitals and clinics, to entities that collect health data and report out on that. So thinking about health insurers, to research institutions and such, also testing sites and laboratories that do health data collection. And then you have public health entities that take data that they receive and transform that into digestible information, thinking on the lines of those who work in state, local, and tribal public health entities. And then feeding into that is also case investigations and patient interviews that come into public entities, public health entities. And then lastly, just data reporting and sharing pieces. So CDC and local public health, and how they deliver this information to their constituents. And so, looking across this spectrum, as you can see, the arrows kind of cycle between everywhere here. And then when you get to the bottom, the question really asks, where can this work embed itself? And I would say that data disaggregation and data equity really can go in any of these areas. And the top just kind of provides some high level sort of examples of data that we might be familiar with, that perhaps we've also worked with or have seen. And in many cases, this data is also not disaggregated. And so again, really working on the front and understanding that data equity can really be embedded in any of these areas, and should be. So let's move to talk about the demographic data collection standards themselves and what that is. I know I've been referencing that in particular, but haven't really dived into what this all is and what this means. So just for some historical contextual pieces of this work, I want to start off with when this process began and when conversations really started to unfold. So some of you may be aware of this and perhaps could have been a part of these conversations in the past. So this predates my time being a part of this process, as well as my supervisor's time, Dan Fernandez-Baca. But we wanted to highlight that in 2011, race ethnicity data was something that wanted to be fully captured with regards to what data we have at MDH and DHS, which came to develop the data inventory, ways that we can catalog that data, that metadata, know what's available, what sort of data sets we are capturing that contain this information. And then in 2014, a group of 40 stakeholders, DHS and MDH, convened to talk about a standard about, you know, collecting race ethnicity information and other variables and demographic identifiers, I'm sure, but I believe mostly focused on race ethnicity. In 2019, the HEAL memo, and so the HEAL memo is a memo received from our HEAL Council, which is a group of community members that had been advising the Minnesota Department of Health on specific priorities that we as an agency need to think about. And they identified that there was a lack of agency-wide data standards and that there was a lack of disaggregated data. And then in 2021, as you can see, that's kind of a timeline skip between some of these date points from 2014, 2019, and then 2019 to 2021. Well, you know, surprise, surprise, COVID had happened. And within that space, again, what really catalyzed the continuation of this work and the very strong support and advocacy and voices from community to help move this, to help create that space and move this forward in terms of, you know, being accountable to those we serve and really having a way we can start thinking about advancing data standards. So in 2021, intro webinars occurred with my where my supervisor Dan was reaching out to community members and different external partners and internal reviewers at MDH to look at the standards that had been drafted, kind of figure out what needs to be done, what needs to be revised, and what other sort of standards need to be considered. And then in 2022, when I came on board to support this work, coming again with from the community and with that community lens in mind, came on board to support this work in developing the ways that we can continue building trust and transparency with the communities that we serve, reaching out to community groups and organizations to continue having conversations about the data standards. And I will get into that a little bit more, but this is kind of the timeline in terms of what's been done so far. The data, this flow chart here, as you can see, is focused on what the iterative process looks like when it comes to the data standards. We know and understand that this will be an ongoing process, a living process. It's not going to be a one-off. It's not going to be something where we will sideline when it comes to this work. And I think a lot of it is, again, about embedding accountability. And so as you can see here, the HEAL memo came in, Commissioner Malcolm at the time provided a response, and then and then the data standards started to be developed at point number 3. And then as you can see, this is a cyclic sort of cycle where MDH expert reviewers looked at the data standards. We moved to community review and expertise. And so where we were right now, and I say we're in past tense, it's because we were at EO approval, so the executive office, in getting buy-in and having leadership, you know, listen and think about the data standards pieces, and then move this into the publishing phase where we can start implementing and thinking about ways to advance this. And so as an update, my supervisor and myself met with the executive office, Commissioner Cunningham, and many of the assistant division directors and division directors to talk about the data standards, where we're at right now, and the important updates that we had, and then continuing again to move through this cycle in future iterations of the data standards. So going back to that piece about our external reviewers, we've had many folks be a part of this process, and this diagram on the right may not be fully representative of all the folks that we we've talked to or that Dan has met prior to me coming on board. But just to highlight and really wanted to use this space to thank all of those who have been a part of this process, all of you who have been, strong supporters and advocates of this work as well throughout the many years that as we talked with local public health to other individuals from state entities, state ethnic councils and organizations such as nonprofits, to academia individuals from the U of M, and our federal and Region 5 partners, where with all these voices and eyes looking at the data standards, providing input and support of this, we've been able to reach where we are now in terms of making sure that we're at this stage where we're ready to move forward with data standards and think about how we can continue co-creating and collaborating with all of those who do interface with data and, again, bringing in community. So diving into just the data standards briefly here, I won't be digging into too much of the technical nuances or some of the rationale for some of the questions per se. If there is interest, please don't hesitate to reach out to Dan, myself, or Nan. I can share our emails to the MPHA folks to share with all of you if that's of interest after the end of the call here. And so we have first looking at Hispanicity, and as you can see here, we have a level 1 and level 2 designation. When we think about level 1 and level 2 in this context, it really is just thinking about at level 1, this is not these questions are not questions where you would have both of these question stems in a data capture tool or health surveillance instrument. It's either or. And so level 1 would be your more generalized, more commonly used data standard tool. And this is for the context that, some data sets have to have specific funder requirements or different ways that they have to report data. And so, this speaking to that, of course, I think when it comes to data disaggregation, we're really looking to advocate for the level 2, whereas you can see here, you have more disaggregation of the community groups, the demographic identifiers. So as you can see here with Hispanicity, we have these community groups, and many community members for these questions really provided the insight and their expertise in providing suggestions. So we added, for example, Spanish to the question stem in from community members' voices. There, instead of as you can see here, where there's a not listed above for community group, many have voiced that instead of using other, where there's that context, that connotation of feeling othered, that it would be best to use this piece of not listed above instead. And then, of course, when we get to questions about race and ethnicity, instead of asking directly about race and ethnicities, things such as how do you describe yourself really does make a difference. We've heard from community members that, if we, and quote, if we don't see ourselves in the data capture tool or data, oftentimes we either won't identify as anything on that list, or we may, mark something that because it doesn't identify ourselves, it's just not an accurate representation. And oftentimes it might be inaccurate. And so, looking at level 1, this is just your standard OMB 15 categories with some word changes. You have your large racial umbrella categories, as you can see here. And then moving on to level 2, now this is where, per our Minnesota demographics, we have the breakdowns of specific groups for respective communities. So for starting with American Indian, Alaska Native to Asian or Asian American, Black African or African American, Native Hawaiian, Pacific Islander, white, with their respective disaggregated groups. So you might wonder, how were these groups determined? And given the changing demographics over time, how will the data standards be affected? And so I wanted to say that in particular to this piece, you know, the specific threshold is being used when it comes to looking at these population groups, particularly the census data, but also birth data. So taking into account that we need to be considering both these sources because one or the other may be potentially missing information of community groups if we're and so needing to be considering that piece. And so when we are looking at sexual orientation, we see that for the level 2, we have this was informed by our partners from Rainbow Health, who are supporters and have done a lot of advocacy work around the LGBTQIA+ population. And with that in mind, taking some of their guidance in terms of how to capture this information. So as you can see in level 2, including pansexual, queer, and asexual as part of more disaggregated categories, to a level 1 where this is used in national like census data and other national data sets. And then for gender identity, biological sex and gender identity, having this be a 2-part question. Oops. So this not being a level 1 and level 2, but asking first, what is your sex assigned at birth? And then the second question following that, how do you describe your gender today with the respective categories here? And also noting that for our American Indian and Alaska Native populations, that there is the cultural piece of Two-Spirit. And so really being important to note that we include this piece, this identity, and that it is a culturally specific identity. And so for those who would be American Indian, this would be an option that they would be able to choose from this list. And to take that into consideration for data coding and analysis too, as data around this is collected. And then the last standards focused on disability status. And so disability status level 1 is, as you can see here, more commonly referred to as the Washington short set. And this is information that we are using from the Washington short set with the changes of certain language and tweakings of some of these questions per our reviewers over the course of this time. It is a series of 6 questions that are asked, and you might be aware of this. It's in the American Community Survey and census data, as well as other data sets, again, like BIRFIS, the Behavioral Risk Factor Surveillance System data. And so it asks things about, your visibility, your hearing, whether there's a physical, mental, or emotional condition where you have serious difficulty concentrating or remembering or making decisions, to mobility limitation. And so these 6 questions being stratified in these sort of 6 areas provide some indication of disability, but as you dig into this deeper, you realize that there are a lot of gaps as it relates to self-identification of disability, and also even thinking about within these 6 conditions of hearing and physical mobility and such, it does not show specific nuances of disability and what these specific functional conditions might be, as well as identifying at a more granular level those respective groups that folks might identify with. So that being said, I think if you look at question 2, it will make a lot more sense, where you have a list of disaggregated groups with varying different functional conditions. And to note that this question was informed again by our reviewers and those that we worked with closely. And so that this is a process for this question where it will probably be more, it will continue to be developed as we think about coding and analysis, how these specific groups, if you were to mark, B, C, and D, what that might mean versus an individual who might mark C, D, and E. And so I think really we're at that phase where guidance is being developed and being thought about. And that will really come from also some of the discussions that we will plan to continue having with our community partners and external reviewers, as well as internally. And so let's talk about moving forward and that pathing forward with relation to data standards. So we understand that this is a process that will be ongoing and will continue to be revised and reiterated on and improved. And so many community members have thought about ways we can think about including socioeconomic status variables, language, nativity, name to use, and age variance of these questions. These are important factors that we have to take into consideration. And these are things that for a version 2 of the data standards, you might expect to see as we develop that. And then, of course, implementation and learning from the use cases of these data standards, being whether it's piloted or used in a specific area, really creating that space so that we can come together, learn from each other, and continue building the momentum of having those seeds planted and having them sprout and learning and bringing more awareness to the data standards as this work continues. We at the Center for Health Statistics will continue to have ongoing consultation, whether that's with respective individuals at divisions or our external partners on the data standards, thinking about these things with them, and also, thinking about in our space, how we can start advancing those data standards where feasible. And there's a lot of behind the scenes work going on with that as we speak. And so, again, also thinking about reporting, so how we can share information meaningfully to communities, thinking about that dissemination piece, not just taking and collecting data about communities, but to be able to work with communities, build that capacity, and think about these pieces together. And then intersectional analysis, right? We all have very unique identities, experiences. We might be, again, wearing many different hats or a part of different communities. So needing to bring in that intersectional lens into all of this with the data standards in mind. And that I think, it's very well the case that we as individuals may have our own implicit biases, whatever that might be. And so again, when it comes to intersectional analysis, that really being the piece that we want to highlight when it comes to data standards and those that we serve in any sort of data that's collected. Oops, sorry about that. And so as I get to this slide about the data vision roadmap, some of you on the call might be aware of this and may have been a part of this process as well. The vision for the data vision has been a process where Jessie Carr and her team at MDH have been leading discussions with internal partners and then the external partners, community advisory board that they had convened to look at 5 particular sectors of data and the data equity process. So these are things such as data collection, data analysis, data monetization, data governance, and communication. And so these 5 pillars being a part of this large umbrella vision that we at MDH have in terms of advancing our data equity work and data equity initiatives. So it's been a year-long process, I believe, of folks, as you can see in this timeline, of working with small groups within our MDH divisions to bring in the advisory committee in July and October to refine the data vision. And the data vision roadmap, again, for context, is providing the information and the guidance in terms of what sort of areas and what sort of purpose do we have with advancing this work for the respective pillars. And so, and then developing or thinking about metrics, how we can measure that, what does success look like when it comes to this. And so that being said, the data standards work that I share with all of you is really a pillar of the data vision and roadmap work holistically at the Minnesota Department of Health here. And so given this timeline, so I won't read these boxes off, but as you can see, you have the draft data vision and the feedback that was received from those who reviewed it in November to January. And then with the last two sections here, really then taking that and revising it and looking to finalize that by the end of summer here. And as an update, actually, Jessie and her team and those working on the data vision and roadmap have talked with Commissioner Cunningham and the EO office to have that process approved for their next steps in terms of the data vision roadmap and how to start thinking about that, where to consider implementation and tracking of these pieces when it comes to data equity at MDH. And so the takeaways that I have here is that in terms of the data standards work and embedding accountability, one of the questions that we've often received from community members has really stemmed from this piece about accountability, and that, this is something that needs to be a process where it's not just a one-off, where we have these documents, we have this guidance, and it never goes anywhere, or nothing really comes out of it, right? And so you perhaps this is something that you see oftentimes in policy, and folks in the policy space would argue that it's about that timing and finding that window of opportunity, as well as, of course, bringing in the collective folks, the collective voices to help build the political will, help move things forward. And in particular to embedding accountability, that's what this work has been about in terms of bringing in community and those voices, having them hold us accountable for the work here that we do. And then, as we think about the different areas of where people are in terms of data equity, whether that's a culture thing and not really seeing the importance and implications of data equity, to perhaps we just don't have the resources, to things such as, we need better guidance in X, Y, and Z. What our approach, Dan and myself, have been doing is embedding the notions of data standards and these pieces into the different areas that we interface with, so that if one area ends up kind of having challenges or struggles that we need to deal with, we have multiple gears looking at this, multiple pieces of this puzzle, thinking about data equity, perhaps trying to implement it. And as we continue building out that space of better data holistically, we are building the momentum and paving the way for learning how we're doing, how good we're doing, or maybe how bad we're doing, and really learning from that and continuing to improve that. So, and then as Mai pointed out, very importantly, we need to understand that data equity isn't a one-size-fits-all approach. Again, this speaks to also the intersectional piece, as well as that many different communities have different needs, different pieces that we need to take into account qualitatively, contextually, and so needing to be holistic in this approach. And lastly, that data equity is a process and an outcome, and knowing that this will be a process that will take a while, time, but also understanding that we need to know how we are tracking and measuring success. And that's something that's really going to be key in terms of the work here. And so for us at MDH, I would say, as we have many different data sets at MDH, one of the key areas is thinking about how we can track, given the data sets we have, how each data set that has data on individuals is changing over time with its data collection practices, implementing these standards. And so with the publication of the data standards here coming sometime in early October, I anticipate, given our discussions with leadership in the EO office, that's what I imagine for our next steps. And then for sources of data, we need to scrutinize those sources of truth. What I'd like to say in this piece is that we only know in some instances what we see when it comes to data, and that also means that what we know can be limited by the data that we have, and though perhaps there is more to the story than that, that sort of piece right there is what causes a lot of whether that's inaccuracies and misrepresentation, further gaps and inequities. This is particularly why, again, when it comes to data equity, it's so important to think about and scrutinize, interrogate the data that we see, that we work with, that we interface with, and really understand as individuals, is this meaningful to those that we are serving? Is this something that is being inclusive and is holistic about the ways that we are capturing our populations and looking to tackle root causes of problems? So that was my last slide. So I wanted to thank all of you for your time and your attention to this work on the data standards work, and my colleagues at the Hmong Public Health Association, and again, for you all being here in this space. So thank you so much.